Good afternoon. Thank you very much for taking the time out of your busy schedules to join us on this webinar today. My name is Irasima Leroy. I'm an Associate Professor of Geriatric Psychiatry at the Global Brain Health Institute at Trinity College Dublin, and I'm one of the directors of the Dementia Academy, which aims to support the knowledge and practice of frontline clinicians. The COVID-19 pandemic is having a significant impact on all of us and how we are practicing medicine, particularly in the way we are supporting older people with dementia and their care partners. In adapting to this new reality, many clinicians around the world have started to change their clinical practices to incorporate remote working using telemedicine type approaches. And for those working in the realm of memory services, a key element involves cognitive testing. Remotely delivered cognitive testing can be quite basic, or it can involve a much more complex approach under the rubric of teleneuropsychology. So today we're not going to focus on the wider issue of teleneuropsychology. There's detailed guidance already posted on the internet, and also you can find it on our own website. We've already addressed this topic in our previous live webinar from May 1st, which is recorded, and the transcripts are available on the website. So today, I'd like to focus on a very particular issue, namely the application of remote cognitive testing, either telephone alone or video conference, for older people with a particular focus on people with hearing and vision impairment. So to help us explore this issue, we have two panelists. One is Dr. Walter Wittich from the School of Optometry at the University of Montreal in Canada, and the other is Dr. Natalie Phillips from the Department of Psychology, Concordia University, Quebec, Canada. Both Walter and Natalie have contributed to the development of the Montreal Cognitive Assessment tool, the MoCA, which is one of the most widely used cognitive tools in the world. And recently, due to the push for remote assessments, there's been a lot of interest in using the MoCA remotely. And so we're going to talk about that today in the context of people with hearing and vision impairment. And I'll just add that the views shared today are those of the panelists and not the views of the institutions that they work for. So I'm going to start by addressing my first question to Walter. So Walter, for older people with dementia, how common are hearing and vision impairments?
Thank you for inviting me, Ira. This is a wonderful opportunity to talk about sensory cognitive aging today. It's a body of research that exists roughly for the last 30 to 40 years. There's a lot of work done on how the senses and the brain change at the same time as we get older. And so it's not surprising that there are cognitive problems that are associated with vision impairment and hearing impairment. We've known that for some time. The proportion of people just in the regular older population that will have hearing loss after the age of 65 can be as high as 50%. You would expect roughly around 20% of older adults to have some issues with their vision as well, and you may add another 20% of people with dual sensory impairments, or with vision and hearing impairment at the same time. These numbers go up quite a bit if you look at the population that has dementia as well. That can be anywhere between 70 to 90% for hearing loss and 50 to 80% of people that have a vision impairment. And we've replicated that recently in the Canadian longitudinal study on aging, where you can basically assume that 1 in 3 older adults over the age of 80 will have both a vision and a hearing problem. These numbers are even higher if you look into long-term care, where you will find the triple threat. You will find people that will have dementia, vision loss, and hearing loss, and these proportions get very, very high, and therefore need to be considered in the care of older adults.
Thank you very much, Walter, for outlining that so carefully. So clearly this is a huge issue for the people who attend memory clinics, the majority of whom are over the age of 65. Can you just outline what the impact is of either a single or a dual sensory impairment in people at risk of or already living with dementia?
I think that the easiest way of looking at the impact of any kind of sensory loss, whether that is single or dual loss, is that basically all aspects of life are affected. Even in our webinar right now, we presume that the people that are attending this webinar can see and or hear us. So vision and hearing as our dominant distance senses tell us so much about the world around us. It's not surprising that mental health is affected, depression increases, anxiety increases. There are many other aspects of mental health that are linked to declines in sensory capacity. It's also not surprising that physical health is affected. People will stay at home sometimes because they will be afraid of going out into the world, therefore they get less exercise. There's a gain in weight. There are all the associated health problems that may come with that. And at the same time, social health is affected. People are lonely. People are isolated. They have less cognitive stimulation. Suddenly, you enter this type of spiral where their mental well-being, their cognitive well-being declines simply because of a change in their sensory capacity.
So thank you for raising those issues. And of course, social isolation and loneliness are hugely prevalent at the moment. And we've talked about this quite a bit on the Dementia Academy, particularly in the context of older people. So that being exaggerated by having hearing and vision problems. So I'm just going to turn to Natalie now and ask if you can describe some of the challenges that people with hearing and vision problems have when undertaking cognitive assessments.
First, thank you very much for the opportunity to participate in the webinar today. I think the questions that you're raising are very, very important. So what are the challenges faced by an older adult with hearing and vision loss in taking a cognitive assessment? Well, of course, our ears and our eyes are the portals to the brain. So when we're asking someone to look at an object, to identify what it is, to listen to a list of words in order to remember them, we are really requiring somebody to rely on adequate sensory perception. And I think one of the challenges is for us to understand that even if someone seems to adequately hear or visually perceive an item, that, you know, the work is done. It has gotten into the brain. It will be processed in all normal ways, and we know that that's not true. We know that older adults with hearing and vision loss have there's increased listening effort, increased effort in a variety of cognitive tasks. And we simply don't understand the impact of having a hearing or vision loss on these upstream cognitive processes. So it's not simply the case that if someone hears or sees something, then, you know, all bets are off, and we can assume that the cognitive testing is valid.
Natalie, thank you for that answer. Can wonder whether we can now turn to specifically talk about remote cognitive evaluations, particularly for people with hearing and vision problems. You've been involved with the development of the MoCA over the years. Can you please outline briefly the guidance offered by the MoCA developers regarding its use by telephone or video link?
Sure. First, I'd like to just clarify that there was some communication from the MoCA website suggesting that there are validated uses of the MoCA for audiovisual conferencing and for telephone administration. And as one of the original developers, I think we must be more cautious about some of the information that was transmitted by the website. Let's take a step back and reflect on what remote cognitive testing involves. So it could be either video conferencing, which I think is preferable, or administration over the telephone. Video conferencing is preferable really for two reasons. First, there are the availability of visual speech cues. So we know that being able to see the person that you're speaking with significantly improves auditory speech perception. And it does so for two reasons. First of all, you can see the helpful visual speech cues to be able to identify spoken words. So it makes the perception of speech much easier. Also, when you're communicating visually with someone, you get all sorts of meta-linguistic cues as well, that, you know, the nodding, the smiling is all very important in reassuring a patient that they are performing well, that the clinician has rapport with them. And also the clinician gets cues as well. Perhaps the patient didn't hear something adequately, or perhaps they're confused or anxious about something about the interaction. So video is preferable. The telephone is more challenging because the telephone is a more impoverished way of communicating. Now, one thing that I think is important to understand is all of these devices are going to differ. So whether you're communicating on a landline, on a cell phone, those have very different acoustic properties. Video conferencing itself will vary. There'll be different devices used by the examiner and by the patient. And so we know that things like display size and transmission lag will add a significant amount of variance in what we used to do in a very standardized way. So because these standardized procedures have gone out the window, we now have to be very cautious about the process of assessment.
So Walter, considering these special circumstances of people over the age of 70 who might have hearing and vision impairment, what are some of the challenges that they may face themselves when being tested?
I think that the easiest way of looking at this is that it comes down to two very simple concepts. One is visibility, the other one is audibility. Some of this is already touched by what Natalie was saying earlier, but since we're interested specifically in people that have potentially both impairments, in many conditions, people will try to use one sense to compensate for the other. And that becomes difficult when both senses are impaired at the same time. There are a couple of behavioral tricks that you can implement to make sure that visibility and audibility are actually happening. If you're not sure whether somebody can actually understand or properly hear what it is you're saying, ask them to repeat it back to you. If these instructions that you have given may not have made it through, simply ask your client or your patient to repeat them back to you so you know whether this information has made it through. There are some interesting little tricks that I've picked up with time. For example, sometimes I will communicate with people that when they need to look at something on the screen, I see them leaning forward and there is some effort going on. That tells me that when they were at their original distance, they may not see everything that I might display, including my own facial expressions. So that is a behavioral indicator that there may be a visibility problem. You may also observe that when there's a potential hearing problem, not always is the hearing loss equal in both ears. People may have a better ear or they may have a dominant ear. You will see that while you communicate with them, they may turn their head in order to use their better ear to better listen. That's also another indicator that there is more effort involved on their side to be engaged in this testing procedure. And as Natalie mentioned earlier, this effort that goes into listening is now not available in terms of energy for encoding the information into your memory. So these listening efforts and visibility effort components have to be considered because they will come out in your cognitive scores.
Natalie, some people have suggested adapting the items on the test or altering the mode of administration. Can you make some comment as to whether this is appropriate and also how these issues might affect the validity or the reliability of the test and its cutoff scores?
I certainly understand that the COVID-19 situation and the altered clinical situations in which we find ourselves will dictate flexibility, the need to be flexible. We're all very motivated to continue to deliver the best care we can to our patients. But it's important to understand that it's not business as usual when it comes to cognitive assessments now. So we certainly have to reflect on the impact of these altered clinical situations and assessment situations on the impact of the validity and the psychometric properties of the tools that we're using. So let's take a critical look at the word validated. To me, the word validated with regards to a cognitive assessment tool means that we understand the psychometric properties. We understand its sensitivity and its specificity. We have shown that the cutoff scores are appropriate, specifically for the patient groups that we're trying to offer care to. So recall that the MoCA was specifically designed to detect mild cognitive impairment. So that requires appropriate cutoff scores for that group. We can't assume that they can be used in other groups without doing those validation studies. Now, in the unusual situations that we find ourselves now, where we're talking about doing video conferencing or telephone conferencing with our patients, for the reasons we just discussed, hearing and vision become paramount. And so we don't have validated studies at this point understanding the relationship between if an older adult has a significant degree of hearing loss or vision loss, what does that mean for the cutoff score on the MoCA? So I think that we have to be very cautious in assuming that the cutoff scores from the universe we used to live in are still appropriate. I do have some comments about the alteration of test items. Of course, we're in unusual circumstances now when we're providing video conferencing or telephone assessments, but it's crucial to understand that if we change the items on a cognitive test, you're changing the test. The items themselves relate to cognitive domains. So what we saw, Walter, our work with Walter, when we eliminated the items that were visually based on the MoCA, we saw fundamental changes in the psychometric properties of the test, because in those cases, those items are very much tap into the executive function domain of the MoCA. So we can't substitute items and assume you're measuring the same thing. So asking somebody to describe a clock, or perhaps saying where the arrows point on the trail and what would come next, is simply not the same thing. They may prove to be perfectly good substitutions, but we need to have the data to demonstrate that. So with regards to telephone administration, I do have some practical suggestions. For one, I would suggest not to do the letter tapping subtest. It's too uncertain. It's not clear whether the patient heard the item, whether the clinician didn't hear the participant's, the patient's response. And there could be timing lags that interfere with being able to score that accurately. I also think there was a very important point that Walter brought up, which is the engagement of attention. When you're communicating with someone over the telephone and we don't have visual cues to keep us socially engaged with each other, it's really hard to evaluate whether there has been a lapse of attention due to the telephone situation. Other practical suggestions are when administering the MoCA at home, I think the item where we ask about orientation, where are you, is no longer valid. It's simply much more easy to say, I'm in my home, than to say, well, I'm in the hospital clinic, I'm in the the name of the hospital, and I'm in the Department of Psychiatry or Geriatric Medicine. So the difficulty of the items will be different. And we do have to reflect on whether we're measuring the same thing under these unusual circumstances.
So thanks very much for that detailed explanation, Natalie. It sounds as if we need to approach this with a significant amount of caution and thought. So Walter, just let me ask you, in some circumstances, we will find ourselves wanting or needing to do a cognitive test over the phone or using other remote means. What would you suggest we do in order to ascertain whether it's appropriate in the circumstances, particularly from the perspective of hearing and vision impairment in an older person?
I think that this is where my pragmatic side comes out. I think that some cognitive screening is better than no cognitive screening. So there is information to be gained, even if the situation is not perfect. So from that pragmatic point of view, there are some pragmatics about vision and hearing that we need to touch on if you engage in this exercise of screening somebody via telemedia or telehealth, for example. In terms of hearing, you know, we have these standardized questions that people often use in epidemiological studies, like how would you characterize your hearing if you have a hearing aid and if you're using it. The thing is that this is a beautiful research question, but that's not necessarily all that practical when you're just trying to figure out if these people can hear you. So I would start with something like, do you actually have hearing aids? If that's a no, then we know that we don't need to worry about that. But if they do them, are they wearing them? When was the last time they changed their batteries? Are they turned on? Just to make sure that we're under the best possible situation here. You may or may not be able to tell while you're communicating with people, but there may be background noise in their environment, and that may severely interfere with what's going on. Just ask them to check that the TV or the radio are off, or if they can be in a room in their home that is relatively quiet. This will already make audibility a lot better. And then, of course, you do want to simply ask them in sort of a gentle way how they judge their own hearing. But it's no news that many people will think that their hearing is fine, everybody else is just mumbling. So that question may not always get you to the answer that you're looking for. It's similar for vision. You want to make sure that people are using glasses. If they're wearing them, likely they would have reading glasses. If they have already had cataract surgery, they may not have any reading glasses anymore that they don't need to, but just check whether they are actually wearing what they would usually wear if they are close to a computer screen, so they can actually see what is going on. And then you might want to follow that up with a question about whether or not they have ever been told by their eye care professional if they have an age-related condition like macular degeneration or cataract. People may actually know this and may be able to tell you, which gives you some context. And that is really the point here. Having all of this information will give you context of how the cognitive screening is going to go. Because if there are problems that emerge here or there that under normal circumstances you might ascribe to a cognitive issue, if you have the context of a possible sensory impairment at the same time, this gives you context to say, well, it may or may not be purely cognitive. Maybe the senses play an important role here.
Natalie, I'm going to ask you to give us the final word. Considering all this information and the very important issues you and Walter raised, what is your final advice regarding the use of the MoCA or similar cognitive tests in remote settings for this population?
I'd like to go back to a point that Walter made regarding listening effort. And I think there's an important consideration here. Many of us work with patients and they're being assessed in a language that isn't their native language. And one thing we have very little evidence about is the impact of listening in your non-native language and the challenges that places on an individual in terms of communication and understanding and responding in a clinical assessment. So I'd like to flag that as another area for us to be cautious about. If you're carrying out a cognitive assessment with someone in their non-native language, there will be an additional burden on that individual in terms of participating in the assessment and being able to understand all of the information that is being presented to them. So my final comments about doing remote assessment and cognitive screening with the MoCA is that I wholeheartedly understand the desire of clinicians to continue to offer the best care to their patients. And I think certainly the MoCA can continue to be a familiar vehicle to elicit behaviors and to make clinical observations. So I do believe that we can engage in these clinical activities in meaningful and appropriate ways. But I think we have to remember that these are non-standard testing conditions. And so we really can't assume that the cutoff scores or what we knew previously still applies. So here the role for clinical judgment and acumen becomes paramount. We have to, as a good clinician knows, appreciate that an assessment is it's a process rather than an outcome. And we're not after the score, we're after the assessment and observation of our patients and how they engage in a cognitive screening. So I would say that if your patient passes the MoCA, you can pretty much expect that that score is valid. Unless, of course, they've somehow undermined the test by writing down the words. But, you know, we don't anticipate that too often. But if someone doesn't so-called pass the MoCA, as clinicians, we really don't know why. And it could be for one of many reasons. It could be because of their hearing or vision. It could be because of their anxiety during the assessment situation. It could be difficulty understanding the task. Or it could be reflecting a genuine cognitive impairment. So really the onus is on the clinician, as it always is, to use your clinical judgment. I certainly wouldn't use the MoCA under these conditions to make any kind of medical legal decision. So as always, I think we can continue to use these familiar tools and to help them guide our clinical work in identifying whether our patients need appropriate referrals, appropriate follow-up, to engage in careful care planning. And I think it would be very important to be able to bring people in for reassessment when the situation allows for it, to be able to do a more fulsome in-person evaluation.
So just like to thank Walter Wittich and Natalie Phillips very much for their very insightful and thoughtful comments, and articles that they've written on this topic can be found on our website. Thank you very much.